I split it into 3 parts so we can get coffee in between. First one's just diagnostic testing, symptoms, sign, diagnostic testing for wet AMD, classifications and variants. And a lot of this is stuff you need to know, and some of it's new and interesting. Stuff that's important is neovascularization. Neovascular AMD starts in Bruch's membrane. So what you get is degenerative changes in Bruch's membrane with drusen. It's pretty much dry AMD. Drusen thickening with lipid and proangiogenic environment. And then CNV, as far as we know, starts in Bruch's membrane and perforates for most of the parts. Macrophages, and fibroblasts are involved, and you can end up in the hypertrophic scar. The RPE cell is a center for wet AMD, and there's something between the RPE cells and your immune system and your vascular system that interact to cause the AMD. It was actually a surprise with when the genome-wide testing was done for genes in wet AMD, the complement came out. No one thought that was going to happen. So it turns out the complement factor genes are important. So there's something with complement in AMD. Complement has about 30 proteins, and it's your innate immune system, and there's some that predisposes people to AMD, wet AMD, and then also oxidative stress, which we know because the antioxidant vitamins help with AMD. And there's something with aging. There's other cytokines that might be important. There were studies, the VEGF-A is the big one, that all the drugs work on VEGF, and they seem to help with wet AMD. The platelet-derived growth factor drug that was tested a while didn't work, and Eylea has a anti-VEGF and anti-placental growth factor. So there's other cytokines that are important. And also inflammation probably plays a role because steroids do help. I have a friend out in California who was doing a gene expression study with steroids in the eye, and he found that I think it was 40% of your genes express differently when you put steroids. So there's all sorts of things that help with AMD. The thing that's so frustrating about wet AMD, which I think is ultimately going to be helpful in our future treatments, is as complex as the retina is, the RPE cells are simple. So RPE cells are just a monolayer, and that's really where AMD starts. So if you could do something to replace your RPE cells, you could fix AMD. And that's where that laser study was done. There was laser for dry AMD, and the idea was you would stimulate them, they would reproduce, and you get new ones. And there's some very early trials now on putting a sheet of RPE cells under the retina for people with vision loss and dry AMD, and that seems to help. So the nice thing would be to get the RPE fixed before the retina is damaged. That was the macular translocation too, which I used to do. The idea was if you could take the retina and put it someplace healthier. So AMD really is definitely an RPE disease. So quickly, what are the signs and symptoms of AMD? Anybody know any? What sort of symptoms would you expect someone when they get wet AMD to come in with?
Central blurry vision in the very center of the central blur.
Yeah, so blurred vision is one. What else?
Metamorphopsia
is another. That's a big one for wet AMD. So pretty much blurred vision, metamorphopsia, and then what sort of signs do you look for when you look in the eye?
Hemorrhage in the neck.
So blood's bad.
Drusen, like soft drusen.
Yeah, drusen accompanying blood.
Like subretinal fluid?
Yeah, fluid. So if you see fluid, blood, intraretinal fluid. Now there's the OCT, so you just scan them. But we didn't always have that, so we used to have to look for things. So signs, so you get recent onset of decreased vision, metamorphopsia, scotoma, and then subretinal, intraretinal fluid, and exudate and/or blood. So I have pictures. Oh, so practical. So I put questions in just because it gets boring. So a patient presents with vision change, and they have none of those. They have no signs or symptoms of wet AMD. You look at them, you ask them. Well, they have the symptoms, I'm sorry. They present with vision change but no signs of wet AMD. What's your next thing you're going to test? What test are you going to get? OCT. So you get your OCT, and you do this happens regularly. You get an OCT, there's no fluid on the OCT. Anything else you'd want to maybe check? Oh, no, it's other testing for wet AMD. So if someone, that 75-year-old man comes in, you get an FA and ICG. So you get your FA, and I get an ICG often because sometimes the FDA won't show it, and those are both good. And then there's one more thing I usually, so you're not, just probably not wet AMD, because our scans are so sensitive and our FA and ICG are so sensitive. but you still can't be positive. Sometimes people will see things, will notice symptoms before we can find it. So I always bring them back for a 6-week follow-up. And then at 6-week follow-up, there's no change, I let them go. So for wet AMD, that's sort of your standard presentation. Someone comes in, you do your testing, it's negative. I used to let them go, but then I'd have people come back a year later with severe vision loss and say, well, I saw you, so I figured, whatever. There was nothing you could do. I never understand it, but people will lose vision and I not come back in.
Are these people who have dry AMD?
Yeah, they usually have dry AMD and they're presenting, and the big thing is are they converting to wet? It used to be critical to find it quickly when we did laser, but even now, this, basically most diagnoses, the sooner you find them, there is a medical thing where a delay in diagnosis is considered inappropriate. So then your signs are subretinal fluid, intraretinal fluid, subretinal fibrosis sometimes, exudate, blood, pigment or gray ring, and RP elevation. And here's pictures. So this is someone who presented, I'll show you more pictures of this person later, with wet AMD. There's fluid and there's exudate. Exudate's not super common in wet AMD because in order to get exudate, does anybody want to say real quick where exudate comes from? Why you have it in the retina?
Protein from...
Yeah, so there's protein from the fluid, but you don't get it acutely, you get it later, because you have to have had fluid there for a long time. Mm-hmm. So exudate means there's fluid that's absorbed. Your body has trouble absorbing the lipoproteins, and so there's fluid leaking. So this is something that's been going on for a while, and typically AMD is quicker than that. So exudate's usually a diabetic thing, but you can see it in AMD, but it means it's been there a while. And this person has fluid you can clearly see next to the nerve, so subretinal fluid and exudate. What do you see on this one? Hemorrhage. So hemorrhage around a PED, especially that distribution. It's definitely subretinal, and so that's subretinal hemorrhage. Sometimes you see a little intraretinal, and then what's this one illustrating? A finding for wet AMD.
Is that like a steamy kind of membrane?
Yeah, it's that gray ring. So you see a gray ring. Sometimes you'll see a gray. This is like a super classic, super well circumscribed, probably type 2 wet AMD. It's not a common presentation, but you'll see. This was a younger, this guy passed away. He was a real sweetheart. He was a 62-year-old guy, started treating a while ago. He was a smoker. He was an engineer. He used to travel everywhere. He did well with shots. And then what's this? This sort of funny-looking macular appearance. It's kind of whitish. So when you see white, what do you think of that?
Ischemia or fibrosis?
Fibrosis, yeah. Yeah, so with white, it's subretinal fibrosis. And sometimes that'll be the presentation. Typically, the subretinal fibrosis is older, but sometimes things will come up fibrotic. I still don't know that I don't understand it. I don't know if anybody understands it. Sometimes diabetics and sometimes macular degeneration patients will present. They'll present either with neovascularization. Neovascularization is always fibrovascular. And sometimes it's more vascular and sometimes it's more fibrous. And I'm not sure. I think it's probably something about the person. But it's diabetics is striking. You'll see, I saw somebody this week. It was, the eye looked, it was all fibrovascular proliferation everywhere. And very, it's just way out of proportion. And this is someone where they went to kind of fibrous proliferation. And then what's this? We talked about this earlier today. This is a striking example. This is that,
RP rip.
Yeah, it's an RP rip. This is like a super classic RP rip. So this is somebody who RP ripped on me about a decade ago. And it's not that Eylea one I was talking about, but somebody RP ripped. I treated, this eye I believe is 20/40. This person ended up with very good vision, and you could see the yellow pigment. The RP rip kind of goes through the fovea, but an RPE tear is something you see in wet AMD. So classifications of CNV. This is kind of newer, but there's now we talk about type 1, type 2, and type 3. So type 1 is when the CNV is under the RPE. So that's the one on the left there, that little red circle there. I made that myself. And that's most AMD. It's choroidal neovascular membrane stays under the RPE. And it tends to be, type 2 is where it grows sort of through Bruch's membrane and ends up subretinal. And type 3 is the RAP lesions where they start, we think, they start in the retinal plexus, which is all the way up there. When I initially made this illustration, I made it wrong. Your outer and inner, your superficial and deep capillary plexus are on your in your internuclear layer. Excuse me. So they come all the way down from that, and that's the type 3. But then the RAP lesions do grow from the retina, grow under the retina, and you typically get a PED. So those are the way we classify them. I have to say, I don't know that you can differentiate this right now on OCT that well. So you can. Sometimes you can see it clearly subretinal. That subretinal white hyperreflective material, which is strangely enough in your book this year, I think it was clearly the book was made. They edited the book. This year is the 2018. Well, you guys might not have the 2018. The 2018.
Available.
Yeah, it's available. The 2018 Retina got revised. They revise each one every 3 or 4 years, and this was clearly revised during the, I think it was the Opthea trial for the anti-platelet or PDGF, anti-platelet derived growth factor stuff, where they were worried about the subretinal hyper. That doesn't matter anymore. But so type 1 is sub-RPE, type 2 is subretinal, type 3 is intraretinal. And before the anti-VEGFs, type 3 was the worst, but now they all respond pretty well. So that's one thing. And then the second thing you need to know about the neovascular membranes are the fluorescein patterns, which we talk about all the time, but just to have them formally in lecture. There's classic, which is bright pretty early, and bright late and leaks. And then there's occult, where you can't really see it early. And early means within the first minute, I guess, of the fluorescein would be early. So within the first minute, you really can't see the membrane, and then later you get this either irregular elevation or stippling or sort of leakage in the later frames of the fluorescein. Again, occult and classic were before OCTs. And a lot of this was we weren't really sure they were wet or not. Now with OCTs, you just look. So this is a classic one where there's a cartwheel early. So the image on the left is early, and then late it sort of stays the same and leaks. And that's sort of what you expect for a classic. And then the occult, this is 90% of what I see is occult. And this is someone where honestly it's hard to even know they have AMD without the OCT and the ICG. A lot of these are from last week. And the right eye has nothing really within the first minute, just a couple little pig hypofluorescence. And then in the late frames you can see little leaky areas. And then there's predominantly occult and predominantly classic. So this is one where there's one area that kind of lights up more in the early, and then the rest of it stays sort of stippled. So those are the classifications. So you got the type 1, type 2, type 3 going from the outside in, and then occult or classic. So what would you call this? Would you call this occult, classic, or mixed? I put the early and late FA on.
Occult.
Yeah, it's occult. So it's got stippled hyperfluorescence. You don't really see much early. I put the OCT just so you would believe that it was a wet AMD case, because you can't always tell. And you see a little subretinal fluid there, and that's a classic occult one, or typical occult one. And these are all probably type 1s. I have to say, when we were doing subretinal surgery, some of this mattered. And if you are thinking of displacing a subretinal hemorrhage, some of it matters. There was cases like where if you do have a subretinal neovascular membrane originating from the retina and you try to remove it surgically, that gets really messy because it's integrated with the retina. And if you try to remove one under the RPE surgically, you pull out the RPE with it. So if someday we ever go to surgery, back to surgery for something, I could see in the future where we might remove these and put a transplant in maybe, and who knows. But sometimes the anatomy would matter, but at the moment it's hard to say. This is that lady. So this is the one with the occult. Oh yeah, this is from 2015, these pictures. I just saw her back again this week. And she was kind of interesting because we talk about treat, like we were talking in conference. And she's terrified. This woman was terrified. She hated the treatment. She was terrified. I treated her for exactly a year. I tapered her off treatment, and I've not treated her for whatever that is, September to November 1st. And she's perfectly fine. She's got normal vision. She's dry as a bone. So she hasn't required treatment in over a year. So we'll talk about treatment protocols today. Get through this. But I think you can vary it. And so this is a woman who is not getting treatment. I'm just checking her. You can see she got she doesn't have PVD yet. So fluorescein findings in FA. There's occult in classic. Then there's OCT findings in neovascular membrane. So mostly with the OCT, you're looking at the subretinal fluid is the big one. So if you're going to call it wet AMD, there's almost always subretinal intraretinal fluid, and then you'll find the PEDs. You'll see serous PEDs, fibrovascular PEDs. So this has a combination. There's a serous PED over on the right of the picture. The bottom is supposed to be fibrovascular PED, but even the one on top, you can see there's some irregular PEDs on the left. There's subretinal fluid there. Also subretinal hyperreflective material, which is, I don't think anybody's ever going to ask you that, but this one on the bottom is supposed to show the subretinal hyperref. So in front of the RPE, there's that band of material.
Where does that, like, I read a lot drusenoid PEDs. Where is that?
Drusenoid PED, that's when, a drusenoid PED by definition is over 350 microns. Some books have 200, I believe it's 350 in the basic science book, of just a really big drusen. So if you have a bunch of drusen, it's just they connect.
Okay.
So they connect, it's called a drusenoid PED. And there's no fluid usually, so it's not, it's the drusen, there's definitions for sizes, and 65 microns and smaller is small, 65 to 124 I believe is large, and is medium, and then large is over 125 I think. And then once you get over 250 or 300, it's considered a drusenoid PED. All right, so which type of CNV is the deepest one, remains below RP and Brooks membrane? 1, 2, or 3? 1, yeah. So it's going up and out. So just remember, 1's on the bottom. It's once you remember 1, 2, and 3 are easy. OCT angiography, isn't that cool? I got that off their website. So I don't have this yet, but we're going to get some. It shows fine detail architecture, and that you lose the blur from leakage. So you can find neovascular membranes even in places where they're hard to see. I don't think you can see through blood, but the big thing is inside of a PED, it's hard to tell if there's where the neovascular membrane is. The thing is, at the moment now, it doesn't really matter where it is because you just give them injections. So the OCT angiography is kind of, I think eventually it'll be something we use, but it's probably going to go through iterations. And then the other thing I used by permission is I pulled images from the 2018 PAT survey, and this is sort of talking about management. So this is the best way to, I can sort of say what I do, but if you look at the ASRS, which is over 1,000 retina specialists in the country, and they're people, and then there's international, what people do in general. So the one thing is, when you get someone with wet AMD, what's your workup? Do you get OCT, FA, and ICG? For a brand new patient, I get OCT, FA, and ICG. Honestly, I probably don't need the ICG a lot of the time. You're just looking for polypoidal. Most people get some sort of testing. So if you look at US, 26% get FA and OCT, followed by OCT only. 8% get FA and OCT, followed by OCT and FA. And then OCT and FA followed by OCT and FA. I guess it doesn't have ICG. And then the bottom one is only OCT. I have to say, the 28% that do only OCT, I know people in our community that do it. It's people often that are just doing injections. They're retina specialists for the most part. So there are people that will just get OCTs. I don't think that's good. I think because you're going to miss I've seen people from practices where they only get OCTs, and we did the lecture in April on subretinal fluid, and there's dozens of things that will cause subretinal fluid in addition to AMD that you won't pick up without getting an FA. So I would recommend doing both. The thing is, if you're going to do an FA, you need a crash cart. So some people just don't want to deal with that because people can have reactions. Most important thing for following people with wet AMD to see activity, most people look for subretinal fluid. Because people's vision will go up and down. In fact, somebody did look at the studies, and I believe it's 10% of visits in one of the big studies, the vision would be, I think, 2 lines off. So it's not uncommon for someone to come in and their vision just measures terrible. And if the testing looks the same, it's probably just they're having a bad day. My experience in my office is when it's really bright out and we're on time. So if we don't give people time to adjust from the outside, the visions are all horrible. So you have to give people a little bit of time. Most people look for subretinal fluid. And then, macular hemorrhage, any of that. And so then polypoidal choroidal vasculopathy we kind of covered. But just so you know, it's type 1, it's sub-RPE. This is a variant of wet AMD. Multiple serous sanguineous PEDs, you get a network of polyps, feeder vessels. there's a racial disparity. So in Asians, it's 20 to 50% of cases are polypoidal. In whites, it's fewer than 5%. And then there's soft drusen that might not be present. There's a thickened choroid, and you can get subretinal hemorrhage. ICG is better than FA at looking at these, and PDT can be effective. The big study is the Everest. So if you're going to say, I like studies for, if you're doing a research study, you have to define the disease. It forces a definition. So when people are saying, like the patient we're looking at, does that patient have polypoidal or central serous? You can pull like a study and say, do they meet the inclusion criteria? And this was for the Everest study. It's unfortunately a little tricky because they have stereo viewing, which a lot of us don't have now, unless you're looking at the retina. So basically you need subretinal hyperfluorescence on ICG within 5 minutes if you're going to call polypoidal, which that patient we looked at did have. And then you need one of these 6 things, either submacular hemorrhage, subretinal nodules, pulsatile polyps, the channels, a halo around a nodule or nodular appearance of the polyps. I don't think that patient we saw had those. So I'm not so sure that was polypoidal. There was a very good article on polypoidal about 5 or 10 years ago where someone talked about it as a neovascularopathy rather than a choroidopathy, and I kind of believe that. So I think polypoidal is something you see in people who are pigmented, their RPE is strong, and it doesn't let the neovascular membrane out, and the neovascular membrane's mature. So I think but it's polypoidal choroidovasculopathy. This is a 73-year-old woman that I think we've seen this before, but she came to see me. She'd had 2 years of treatment for wet AMD, and she switched to me because of insurance, and her vision was 2160 in the right eye. Her left eye was good. No, 2160 in the left eye, I'm sorry. And this is the left eye, and you can see the exudate there from the chronic fluid, and this is the OCT I showed you before, and they tend to get these funny looking things, and then the fluorescein just shows a filling PED. You know, it doesn't really tell you even where the membrane is. It's interesting. Look at where that is. And then I'll show you the ICG, which shows it way over there on the side. You see that little lacy thing on the left? So that's the neovascular membrane. And then if you look at this patient, so it's got the early filling on ICG, it's got a branching vascular network filling it. You see that coming in from the left is the branching vascular network. So it's got both characteristics. And then the cool thing on this one, it did have a pulsating polyp. You see it there up by the arrow? Isn't that cool? It's on the ICG angiogram. That's why sometimes I'll go in the room, and if you're watching them shoot if you're doing your own injections, you can say, oh, look at this pulsating polyp, capture a video, and they can capture a video for you. And then you can edit it, put it in the lecture. So that's kind of cool. And so I did treat her with monthly Eylea for 5 months, and she did not dry up, and her vision didn't improve. So I PDT'd her, and the fluid went down, and then I also did Eylea, and she ultimately came up to 20/30. And then she switched to another group because that HMO was driving us crazy. You can deal with that when you get older. We're fortunate. This area has 2 million people, Tampa Bay, so even though we end up not participating in insurances that give us a hard time, and this one was just brutal. Anyway, so give me a couple signs of wet AMD, just real quick. This is like a short-term memory thing.
And morphopsia.
Signs, that's the symptoms.
Bleeding.
Signs.
Blood,
Fluid.
and
Subretinal fluid.
subretinal fluid, blood.
That greenish membrane.
Yeah, gray circle. So subretinal fluid, intraretinal fluid, subretinal fibrosis, exudate, blood, pigment gray ring, RP elevation. I can't imagine someone's not going to ask you that. What I would do is stick something in there. I couldn't think of something to put in that what's not a sign. I couldn't think of one. I was having trouble. So I don't know how they would phrase the question, but that's got to be something someone's going to ask you someday. And then differential diagnosis of wet AMD. Central serous is the main one they talk about, because it can look a lot like it and it can appear older. So it's common, you get subretinal fluid, but central serous never has hemorrhage. So there's never blood in central serous. So if you have blood in central serous, it's either that they're anemic or they bled, or it's AMD. There's also a thickened choroid in central serous, and AMD doesn't really have that. It's younger and it's maler. And then acute idiopathic maculopathy and pattern dystrophy. I went back to our April lecture I did on subretinal fluid, and I think you could put all of these in the differential. This is not in your book, but we talked about the different sources of subretinal fluid. I can come from the vitreous, the retinal vascular disruption, optic nerve, choroidal, and cerebrospinal fluid. I have seen people with optic nerve pits who were treated for wet AMD for a long time. doesn't respond because it's not wet AMD. And then the big one, though, that you're going to have trouble differentiating is choroidal disorders. And there's a boatload, goodness gracious, of choroidal disorders. Is that still running?
Yeah.
Okay, tell me if it turns off. It's getting long.
26 minutes right now.
Okay, so there's choroidal disorders, and that's a whole bunch of them. The big ones, I have to say, like I have a patient with dome maculopathy, where the high myopes will have subretinal fluid. Just not. I have some people with posterior uveal effusion. I actually have all these, except like I said for VKH. I don't see VKH much. I've not seen a mitogen activated protein kinase inhibitor subretinal fluid, but I have seen acute idiopathic maculopathy looks exactly like AMD, but it tends to be wet AMD. But it tends to be younger. They even get hemorrhage, but it tends to be younger patients, and sometimes you'll get the Coxsackie virus stuff. All right, perfect. So this is we're not done. This is the first part of the wet AMD lecture. So symptoms and signs we talked about and went over. There's diagnostic testing, and then there's the classifications 1, 2, 3, occult and classic, and then there's the variants. The one main variant you know is polypoidal. And I'll just throw in, the thing about polypoidal is it does respond better to PDT, but as far as visual acuity results, they're probably equivalent with the shots. So you really can do shots for polypoidal if you don't have a PDT. Some people don't have them. Perfect.